For joining this afternoon or this morning, depending on where you are, from where you are joining us. I'm Andreas Reimann, co-founder and managing partner of admedicum. We are supporting the Alliance for Pulmonary Hypertension, a patient-led initiative, a non-for-profit patient-led initiative that aims at sharing knowledge about pH. And one of the most exciting knowledge to be shared is certainly the joint guidelines of the European Respiratory Society and the European Society of Cardiology, which were published in September last year. Our first webinar was on shared decision making, and today I'm very happy and honored to be joined by Dr. Simon Gibbs and by Gergely Meszaros, and they will talk about a second very important aspect of those guidelines, that's the application of patient-reported outcome measures. And you will have the chance to write questions into the chat. My colleague Ro Platica will monitor them. I will monitor them, and then later we will have the chance after the joint presentation. It's a presentation by both gentlemen. We will have a chance to discuss that. And without further ado, Dr. Gibbs, I'm very happy to hand over to you.
Thank you very much, Andreas, and thank you for your kind invitation to this webinar. And good afternoon, Gergely. Perhaps I could have the next slide, please. Just before we start, this is just to declare my conflicts of interest. Gergely, as you see, has none. I'm involved with various pharmaceutical companies, which you see here, in relation to clinical trials. And I also participated in the development of one of the PROMs, which we shall talk about. Next slide, please. So what we're going to talk about in this webinar is patient-reported outcome measures, sometimes called patient-reported outcomes, but we're going to call them PROMs, because otherwise it's a bit of a mouthful. There's a lot we could say about PROMs, but they certainly started life probably around the early 1960s in mental health, and they were used for research at that time. And they're still used in mental health, but they haven't turned up a lot in cardiovascular disease or respiratory disease. There's lots of ways of classifying them, but I just want to draw your attention to an important part of the classification, which is generic versus disease specific. So we're going to talk about both. We would rather want to focus a bit more on disease specific, but generic PROMs are PROMs which can be used in any medical condition. And disease specific are specific, as they say, to a certain disease. Now, if I could have the next slide, please, we better agree what we're going to talk about and what PROMs are. And you don't have to worry about the detail of this. This is the American and the European, the two top definitions, which are the medical agencies which license drugs. And the bottom one is from the latest guidelines, and we'll come back to the guidelines in a moment. And the message you need to take from this is that PROMs are reported by the patient. They are not simply reported by a healthcare professional who, having asked the patient, "How do you feel?" writes down what is inevitably their interpretation of how the patient feels. So this has got to come direct from the patient. And we'll go into a bit more detail about that in a moment. Now, PROMs in general tend to measure symptoms. They can measure impact on life, and they can measure quality of life. Some of them measure all three, some of them just measure one. If we could go to the next slide, please. And I think everyone will understand symptoms and the impact of something on their life, but quality of life is one of these vague terms that probably deserves a definition. And this is the World Health Organization definition back in the mid-90s. Once again, this is, in short, a person's perception of what their life is like. Now, it is, of course, colored by a disease, if they have it, physical health, their psychological state, if they woke up happy or grumpy this morning, the level of independence, if they have a disability. So, can they do things on their own, or do they depend on other people to help them? Their social relationships, can they go out and can they meet friends and family? If they can't get out because of disability, that is a problem. All sorts of environmental factors and personal beliefs. And so quality of life is all encompassing. And that's why a lot of the time people talk about health related quality of life, by which they mean the quality of life related to the disease that we're talking about. For the purposes of this webinar, if we use health related quality of life or quality of life, let's just take it that we're not going to get involved in niceties of difference. It's all the same sort of thing. And what the WHO was able to say back in the mid-90s is that if quality of life is considered in a patient, it's likely to lead to an improvement in the quality of their healthcare. So that really starts us off in the right direction. And so if we go on to the next slide, I would suggest that perhaps we say something about the guidelines. Gergely, what do the new guidelines say? Who are the ESC and the ERS, first of all, and what do the new guidelines have to say about the subject we're talking about this afternoon?
Many thanks, Simon, and let me also welcome everyone who has just joined this webinar. Good morning, good afternoon, and good evening for everyone. It's a great pleasure to be here and have a joint session with Professor Simon Gibbs. Yes, we have lots of abbreviation, as Simon pointed out. We have ESC and ERS. ESC is the abbreviation for the European Society of Cardiology. ERS is the European Respiratory Society. And it's a long history that these two scientific associations are sharing the common guidelines on PH, which is the reason that actually PH is a cardiovascular disease. As we already heard, quality of life is not a very new term, so it has decades long period and history. But once it comes to the guidelines, we have some novelties. If you check the previous one, which was issued in 2015, there are a couple of references to quality of life. However, there's no specific section dedicated to quality of life or patient-reported outcome measure. We can use both terms almost the same, and as we already heard, once it comes to quality of life, we are rather focusing on health-related quality of life because this is what we would like to really measure. Can you please go to the next slide? Many thanks. So, in the previous guidelines, we have some references to the quality of life. So, if you Google or search within the document, you can see some results. However, in the new guidelines, we thought that it would be practical to have a dedicated section to quality of life. We learned a couple of terms and definition of how we interpret quality of life. And once it came to the real definition within the guidelines, we were relying on both the FDA and the EMA definition and pick up the most relevant part, the key element, which is self-reported. So I think that this is the key element once we are talking about patient-related outcome measures. It is coming from the patient. So we put emphasis on this definition. You might know once it comes to drafting sections in scientific papers, especially on guidelines, you have limited characters you need to deal with. Despite this fact, we have unfold a little bit this self-reported definition and said that actually it's a patient experience of living with PH. And we also would like to know how the PH as a condition has impacts on the patient, on the caregivers, if any. And we have a nice list what type of domains we focus on, whether it's intellectual, psychosocial, or it might be goal-oriented dimensions as well. this table is quite complicated, but let me walk you through on this. In the guidelines, we have couple of levels of recommendation. The green means that it's recommended, and it is a 1, how we call it, and we have 2, which is should be or might be considered. For non-native speakers, it might not be very different. I mean, should or maybe is quite similar to us. However, from the guidelines, it's quite obvious that the stronger is the should. And what makes this difference is that should means within the guidelines that there's an opinion in favor of the efficacy or the weight of the evidence. However, once it comes to maybe considered, so not should be, but maybe, it seems that it's less well established evidence. And we received, and there was a couple of discussion regarding this, how we are going to indicate quality of life as recommendation. And we come to a conclusion that unfortunately, we do not have enough evidence to underpin that quality of life measures should be used in a daily clinical practice. You might receive lots of similar questions that, oh, I have good news, I have bad news, with which I would start with. So we have good news. We have the quality of life questionnaires within the guidelines. But actually, we do not have bad news. I would not say that despite the fact it is not recommended with green, it's a bad news. I would rather say that it has paved the route for us, and it's rather needs to improve. So an improvement is needed. So we need to collect evidence, and we need to find ways how we can relate or link quality of life questionnaires to everyday care of patients. Next slide, please. And once it
Um,
comes to quality of life, we need to emphasize that it is not a standalone section. Andreas, yes?
yes, Gergely, sorry for interrupting. If you could go one slide back, please, just to make sure that everybody in the audience, yeah, this one, got it. Is it correct that the orange boxes indicate that they may be considered? It doesn't recommend. It doesn't say they should not be used, but it say they may be considered. That's correct, huh?
Yes, this is right. Yes, this is. I tried to spend more time on this. Probably it was not clear enough for everyone. So the green is recommended. So we have enough clinical data, we
Yeah.
have scientific papers and so on. Orange is not as strong as the green, but it is not. It does not say that it's not recommended. So
Yeah.
we advocate for that it has value added feature in terms of the care of the patients.
Thanks very
So
much.
this is
Thanks
what
very
I
much.
think we should should try in the until the next guidelines to make some real world data and some evidence where we can reassess this and try to put to the green from the orange.
Thanks very much, Gergely, for pointing this out.
Okay, thank
And we
you
can
very
go
much
to the
for
next
the
slide.
question. So as I mentioned, the quality of life questionnaires, patient-reported outcome measures are not standalone tools or vehicles within the guidelines, nor within the everyday care. So once it comes to multidisciplinary team, patients should be inputting data in the discussion and also in the decision within the multidisciplinary team about their condition. And we believe from patient perspective, it's important, and this is the sole tool how we can input data and feed in such kind of discussion. Once it comes to multidisciplinary team and patient empowerment, we come to the very important term which also used within the guidelines is holistic care. So once it comes to patient empowerment, we talked about a lot last time within our webinar, where we have a patient with good health literacy, a patient who knows his condition, a patient who is in the position to start discussion, meaningful discussion with the physician. So this is another step where we can also link quality of life questionnaires, where we have an empowered patient. And last, but not least, how we can use quality of life questionnaires. And I'm really happy that Simon pointed out on this slide is that quality measures. We think from patient perspective that we are providing data within the healthcare system which might have impact on the management of our disease. But I'm really glad that the NHS, so the National Healthcare Services within the UK, started a very good practice in terms of yearly audits, because there's a mandatory tick box within the healthcare providers audit and asking whether these hospitals are using quality of life questionnaires or not. So this is how we see the whole circle is closing. So we have the patient side and also we have the healthcare professional side. Next slide, please. And this is the last slide about specifically on the guidelines, and it was also asked by Andreas previously. So we have classes and levels of recommendation. We have green recommendation. We already talk about PH centers, and we already talk about how they should use patient-reported outcomes within the multidisciplinary team. During our last webinar, we addressed the second recommendation about patient centers collaboration with patient association. And we will spend more time on the last red frame recommendation once we will talk about a bit about ERN LUNG. Next slide, please. So in a nutshell, that was some theoretical part of quality of life questionnaires and patient-reported outcomes. We could learn from Simon how it looks like from the authorities' standpoint. We could learn the theoretical part from the guidelines. But let's see how it really looks like from a physician point of view, how it really happens in the clinical care. Simon, the floor is yours.
Thanks very much, Gergely. I mean, you know, it's very interesting, the concept you put across that patient-reported outcomes in pulmonary hypertension are an evidence-free zone. Really, it's, you know, the global perspective at the present time about patient-reported outcome measures, PROMs, is that by incorporating the patient perspective into clinical care, you improve quality and effectiveness of care. And that really has been shown in many diseases, in many countries, although I should just say it specifically, it's only been demonstrated in the global north. We don't have evidence from the global south. In other medical conditions, it's important. So the question that the audience can consider is how important is it in pulmonary hypertension? So let me just recap where it goes in clinical care in just a little bit more detail. Here is your patient, and they're being asked, how is this disease and its treatment affecting my life? And if we go to the next slide, the traditional way of assessing it for most of my clinical career has been by clinical observation, talking to the patient, examining them, and undertaking appropriate investigations. Next slide, please. But that I can't measure quality of life. I can't empathize with the patient fully and completely in order to know how they really feel. And we know, we know that physicians, and there's considerable incongruence between the way physicians and patients assess quality of life. Patients will see quality of life in a much broader perspective than the physician will think their quality of life is. So there is a gap between the physician and the patient. And could we have the next slide, please? Really, these two things are complementary, and they should both be part of the clinical assessment. Next slide, please. But if you want to measure quality of life, you're going to have a way of doing it, and that is called a PROM. And the PROM provides a systematic, comprehensive, and robust assessment of the patient's needs. And so that's where the PROM comes in. And the consequence of this is that it should affect the management of the patient. If we go to the next slide, please. And it can affect the management of the patient in many ways. And some of these are shown on the outside of this slide. Psychological support is right up there. And because PROMs are very good at detecting psychological or psychiatric risk, particularly with depression. And all of these things in this circle here are open for discussion with the patient. And that's where shared decision-making comes in. And that, as Andreas said earlier, was the topic of the last webinar. And I strongly recommend to anybody who hasn't seen it and wants to know about shared decision-making, even if you haven't seen it, I'm sure you will want to when you see it, do go back. The webinar is on the website and you can go and have a look at it. So the next slide, please. So let's summarize PROMs in general clinical care. This is not pulmonary hypertension. This is the rest of the world. I've said they provide a systematic overview of the patient's perception of their disease. This can be used to guide individualized treatment for the patient. The options arising out of the multidisciplinary team discussions, and those options, as I say, they may be psychological, social, financial, all sorts of things can arise. And there are ways of supporting patients. And that's the whole point of this, is to provide support. If you want the best outcomes in medicine, you want to support your patient as well as provide the disease-specific treatment. And in doing so, they're narrowing the gap between the patient's reality of what it feels like and what the physician thinks is the reality. But critically, the PROMs have been shown in other diseases to narrow this gap, and that's important. And that's probably why, they improve communication, they improve decision-making, they improve patient satisfaction with care. In cancer, they've been shown to increase the discussion, dramatic increase in the discussion of outcomes and how the patient and the physician are going to achieve those outcomes. And in some cases, they also improve quality of life. I would just draw attention to the fact that PROMs are absolutely ideal in a patient with more than one medical condition. So, for example, we know that a patient with pulmonary arterial hypertension and connective tissue disease, they are, of course, linked often, but the connective tissue disease raises other problems and needs for the patient. The advantage of the PROM is that it will automatically, the patient will give you their view of how they are given the burden of disease, but the PROM provides an overview of what is going on in the individual patient, and one can address those issues, of course, appropriately. Now, the challenge is that there's no data to show whether PROMs allow patients to enjoy better health. And you might well say, well, what is better health? And that's the challenge. How are you going to measure better health? I think that's a very difficult thing to do, and I'm not terribly surprised that PROMs have struggled to do that. And PROMs have tended to be looked at because there are lots of weaknesses in the studies that were done. Many were done in the 90s and the early noughties. And although these studies are improving, when you put them together in a systematic review, you mix the whole lot together, regardless of what the disease concerned is, you tend to lose power and these things come out, but you can't prove that the patient has better healthcare. So if we could have the next slide, please. The question then becomes one of, okay, so PROMs in general medicine, surgery, all the rest of medicine, certainly improve the patient's lot. What about in pulmonary hypertension? And do you use them? Gergely, what would you like to say about it?
Thank you, Simon, also for providing a very nice background for PH-specific PROM discussion, because as you might recall, I already mentioned when we were talking about the guidelines that we need more evidence and we need some scientific papers which might underpin the basic theory behind the PROMs. Next slide, please. In the guidelines, actually, we are referring to some papers which were specific regarding pH and advising that PROMs might give us an independent prognostic a hint regarding the patients. But of course, there is another new paper I need to refer. This is coming from the UK. I always say to Simon that we can learn a lot from the UK, so it's very good that we still have you in the ERNs. We can learn a lot from you. But from this paper, we can also learn, which has already been emphasized, that once it comes to pH, I think it's out of question that the disease itself has major or actually some impact, how we say, in a theoretical, scientific way on an overall health-related quality of life. But until we do not provide appropriate evidence regarding this, we cannot refer it into scientific papers. So this is an important part of working together with physicians on this specific project. Otherwise, we as patients, we can say individually that, come on, I see that my quality of life is going down, which means something is not right regarding my treatment. However, for instance, you might see from the medical data and records that it is unchanged or mainly unchanged. So this is the reason we think we need to promote PROs and PROMs. However, we need scientific data behind this. So this paper coming from 2019 underlined, as I mentioned, that the disease has major impact on the overall quality of life of patients. And also, there was a sub-question regarding this, more specific, whether it has some impact on the well-being and mental and emotional life of the patient. And it was, if you see the numbers, I think it's out of question. It's obvious that the disease, however, in many countries, luckily, we are receiving the best possible treatments nowadays available. We still struggling with other aspects of the disease, which should be measured. Next slide, please. And here comes another initiative, which Simon will guide you through. However, let me a little bit briefly introduce ERN LUNG, because that initiative was made under the umbrella of this important network. So ERN LUNG is abbreviation for European Reference Networks, which was established in 2017 by the European Commission based on disease groups. So we have the lung, rare respiratory diseases for lung diseases. We have ERNs for heart, for rare eye conditions as well. ERNs are built up pH sensors regarding our core network, but ERN lung also consists of other disease areas, rare lung disease areas like cystic fibrosis or ILD and other disease areas. We can learn from each other a lot. So this is a nice knowledge sharing platform. However, it's a patient-centric network because it helps the implementation of the cross-border healthcare directive. Luckily, it's quite independent, as I mentioned, so ERN Lung can spend time, energy, and money on those niche market projects where, for instance, the pharmaceutical companies are not interested in. And I'm really happy that Simon stepped up and chairing the functional committee within ERL Lung on PROs, which means that we have other disease areas from cystic fibrosis I mentioned, or institutional for ILD and for other lung diseases, so we can learn from each other. However, we try to be very pioneer on PROMs and started a project which will guide, which Simon will guide us on.
Simon, may I just ask a very silly question? Looking to that map, Sicily and Corsica don't appear not to be part of the ERN, although they are part of Italy and France. Is there any, and Sardinia as well? That's probably just a graphical thing.
Yes, I think it's a coloring problem. So it is. It might occur that we do not have any hospital from that specific island. However, Italy, as it is, or France, as it is, a part of the ERN lung network. Thanks for pointing this out. So it might be some coloring issue.
Yeah,
Sorry.
absolutely. And but the most important message, Simon, and you are going to talk about that, of course, is that the UK is still part of the ERN despite of Brexit.
Yeah, I mean, I thought I would be shown the door, but the UK is no longer a full member. But this is a technicality, and the UK can't vote and things like this. None of this actually matters really. The thing about the ERN, from my perspective, is the most exciting thing is there's enormous amount of patient participation in it, patient organizations and patients, and so it's absolutely an ideal place to try and do some work with PROMs. And that's actually what we've tried to do. Now, the next slide, please. We undertook a survey at the end of 2021, at the beginning of 2022, so just over a year ago, a very simple survey of what was actually going on in the pulmonary hypertension centres. And we got a response from 30 pulmonary hypertension centres, 37 physicians in those centres. And here's just the broad headlines. There's not a lot of detailed data anyway, but these are the broad headlines. And that was, at the time, half of the pulmonary hypertension centres used PROMs in routine clinical practice. That also meant half didn't. Now, the half who don't are not doing anything wrong. Before last year, it wasn't in the guidelines. This was something you could do just if you wanted. It wasn't a main focus of pulmonary hypertension care. With the guidelines, that alters the focus. And in fact, since this survey was done and reported just over a year ago, the number of centres has increased who are using PROMs. In fact, in the different centres, and we're going to come to this issue in a moment, there were 4 PROMs being used. 2 were disease-specific, 2 were generic. I'll come back in a moment to why you might have to use different PROMs and what the limitations are. And the frequency the PROMs were being administered varied between every visit to once a year to less than once a year. And I think the reason for this is that there's no data at all about how frequently you should administer a PROM. So could we go to the next slide, please? I'm going to ask Gergely what he would conclude about pulmonary hypertension from this survey.
Yeah, many thanks, Simon. So we were really happy about this survey, and we already discussed that there's a theoretical recommendation within the guidelines, and that was really nice to see how it actually goes within the practice. after or during elaboration of the new guidelines. So we come to a conclusion that there's no routine clinical practice on this. We already know it or has some assumption, but these data underpinned our assumption. And once it comes to asking if it is recommended or not, we might see responses from some of the physicians or healthcare providers that it may add additional work and time pressure on the busy clinical services. From patient perspective, we usually propose sorting out such kind of questionnaires within the waiting time while patients are in the waiting room so they can fill in the form, or even you can be prepared as a patient and coming with some filled in forms to provide such kind of data to your physician. But anyways, we know that there's a time pressure on the clinical care, which might be more difficult if you are providing sometimes really difficulty measurable data. We are really happy, and you will learn more about various prompts later on from Simon, but sometimes it's a problem. If you have lots of pros or prompts, it may occur that you are measuring not the very same thing. So if the patient is relocating to another city or country, probably the prompts which were previously used may not be continued. So all those data which was collected some for years might not be valid and cannot be referred. Simon already emphasized and underlined that there's no elaborated recommendation how frequently the approach should be used. Once it came to this very nice survey, we saw that it was a very different data we collected from the various healthcare providers. So it was half year or each visit, which almost the same, I know, but sometimes it was only a yearly basis or even in the initial patient visit. And I think from patient perspective, the last point is the biggest challenge for us. And this is the reason I'm hardly advocating for hard data and for scientific papers and more data on this specific issue is the reason that we know that some of the physicians are not enthusiastic about the prompts. We know lots of challenges of this. And from patient perspective, we also know that it is difficult once you are providing lots of data from your very heart and from your very individual point of view. Those data should be treated in a more appropriate way. So not should go to the drawer, but you should receive feedback on this. But I know that it put additional burden on the shoulders of the physicians. So there are lots of questions you can see, lots of challenges we need to face once we try to have a more structured approach on quality of life questionnaires and measures. We talk a lot about various PROMs and quality of life questionnaires, but probably it's high time for you, Simon, to show us some of them, which I think very important for us. And probably one of them is very close to your heart, but it will be your secret.
Thanks, Gergely. Can we have the next slide and the next slide after that, please? So if I was going to show you a slide of all the PROMs that anybody had ever tried in pulmonary hypertension, you wouldn't be able to read it. It would have so much written on it. And actually, it really wouldn't be very constructive. So I put up a slide with just 6, which I have selected. The 4 in green rows are the ones that are being used clinically in ERN lung. I've chosen 2 others that are commonly used in clinical trials. But if your favorite PROM is not there, it's not because it's not important, but it's simply because I can't talk about them all in a short period of time. But there's several things I really want to draw to your attention. If you look at the top 2, there's a good example. CAMPHOR is a PROM which measures symptoms, quality of life, and functioning, 3 different domains. Emphasis 10 simply describes how pulmonary hypertension affects someone's life. Effectively, that's quality of life, but it doesn't measure the other things. The general health questionnaires are about quality of life at the bottom, and the 2 in the middle are important, but I just want to pick up on PAH SYMPACT because it has domains for symptoms, physical, social, cognitive, and emotional impacts. And in doing so, it has 2 scores, but one is for symptoms over the last 24 hours, and the other is impacts over the last 7 days. Now, the when is very important. Gergely's already alluded to you that there are differences between PROMs. I'm going to show you a bit about this now. First of all, the when is very important. So CAM4 says, how do you feel today? Emphasis 10 says, how do you feel at the moment? Which, of course, is more vague. If you go to through to SF36, commonly used in many diseases, very well established, it's over the last 4 weeks. Now, we know that the further away you're asked about, the more severe you will report, or the worse you'll report how you felt. You'll say you were worse. So there is an important effect of time. And then there's an important effect of the number of questions. And the number of questions is inversely related to patients' adherence in completing them. So in other words, if the questionnaire is short, patients like it. If it's long, they're not necessarily so keen on it. And CAM4, to be fair, has got a lot of questions, but it's been used, it started off its life in research. Now, the emphasis 10 was developed by the Patients Association in the United Kingdom. They chose to do it, they led it, and they ran the whole thing with some, and then asked external advice, as any of these questionnaires have done in being set up. So it was created by patients for patients. And they chose 10 questions because it would all fit on a single sheet of paper. And if you go to the next slide, I'll show you emphasis 10. I can't show you the others. They're all far too long to show you on a slide. But if you look at emphasis 10, and I hope you can actually read it. If not, these slides are available afterwards, as is the seminar. You can watch it again afterwards. Wouldn't that be wonderful? If you take just the top one then, the patient's asked to tick on a scale from, on the left, I am not frustrated by my breathlessness, to on the right, I am very frustrated by my breathlessness. So the whole thing is done along a scale, and the patient responds along a scale. And it's short. If we go to the next slide, I just want to show you, and this was chosen with research in mind, because emphasis 10 and PAH SYMPACT are used in research, as are the others, I might say. But I wanted to show you with the PAH symptom score of PAH SYMPACT, how that relates to emphasis 10. In fact, only 4 of the symptoms in the symptom score have any relationship to what appears in emphasis 10. So you can see there's a lot of difference between these 2 questionnaires there. And indeed, if you look at the impacts, there are just 3 impacts. Next slide, please. There are just 3 impacts which are roughly similar between the 2 scores. So it does bring me to say, when, and I don't suspect we should go into the detail of this, but when it comes to do we just give out a PROM? The answer is yes, but you need to be very careful what you give out, because you need to be sure it can answer the questions that you want it to answer. Now, there's just another couple of things to say. If you administer the PROM in a different language, it has to be scientifically validated in that language. So there's extra work to do. Not every PROM is available in every language, although the generic ones tend to be almost available in every language because they've been around longer. A lot of these PROMs do have copyrights, and sometimes there is a fee which has to be paid to use it. And so there are a number of issues which are country specific. And in Europe, with our large number of languages, this is difficult. And the other thing to say is that there are no PROMs for children. So you have to go and use a generic PROM for children, and you have to choose a PROM that is in your language. It's easy for us speaking English. There's lots of things in English, but it may not be the case in other languages. So next slide, please. So I'm going to ask Gergely to say something about PROMs in clinical trials. Gergely, this is your last stand at the presentation, I think.
Yeah, many thanks, Simon, for this overview. Let me briefly recap where we can use PROMs, because I think it should be important to understand the whole picture of we are talking about. So we already talked about using PROMs in audit, which was a quite short present part of our presentation. Previously, we talked about how PROMs can be used in clinical practice, so in management of patients. However, there are other possible use of PROMs. We can use as patients for self-reflection. So for us, we can see a nice trend how we are doing. But Simon already pointed out that there are very great possibilities within the trials to use quality of life questionnaires. Next slide, please. It's a very complicated slide, and I know we are a little bit running out of time, but I would like to emphasize that patients are in the center. And you can also recall from our previous webinar that there was an official presentation of the novelties of the guidelines where patients were in the center. So here we see that patients are also in the center in clinical trials. So luckily, there was a previous trial where we have patients in the medical steering committee. So now we are part of how we are structuring initially the trial, where we can see what type of endpoints, but Simon will go into details regarding this, how we can structure the endpoints, and in terms of endpoints, whether there's any possibility or recommendation we will see from Simon to use PROMs or quality of life questionnaires. However, there are other points where patients can be part of clinical trials. You can see from this very nice slide that regarding post-trial, now we call as phase 4 trial or phase 4 of the trials, there is also a role for patients. So I set up the scheme for you, Simon. Let's see how the World Symposium is proposing a step-by-step approach of using within clinical trials the patient-reported outcome measures.
Go to the next slide, please. Thank you very much, Gergely. That's great. The World Symposium is another organization, and I don't think we have time to explain that. But in short, it meets. It's the world of pulmonary hypertension globally meets every 5 years and makes some recommendations. They're not as strong as guidelines, but it provides an update on the whole subject between the guideline publications. And in short, since 2008, I guess there are 3 things to say. First of all, that PROMs have been recommended to be used as a secondary endpoint in clinical trials. That means the whole trial doesn't fail or succeed on the result of the PROM, but the PROM supports the results of a primary endpoint, which is, for example, frequently in pulmonary arterial hypertension trials, the 6-minute walk test distance. The second thing to say is including patients in the clinical trial design is very important. You could have me going the whole afternoon or evening on why patients should participate in clinical trials and how they should do it. And I think we need expert patients on clinical trial committees, because it's very easy to go off beam and not be addressing what concerns the patients. And the third thing is a proposal that perhaps the PROMs could do better than a secondary endpoint and might become part of a co-primary endpoint where there are several things which make up the primary endpoint on which the trial hangs. There is the people who have to finally decide in most trials what PROMs are, what is acceptable as an endpoint for a trial, are the regulatory authorities. Because if you don't use an endpoint that the regulatory authorities accept, then you can't get your drug licensed. And so the drug will never be available. There are lots of technicalities and issues regarding this, which I don't think we should go into now. But I hope overall that what Gergely and I have said, and perhaps we could go to the next slide, please, will give you a flavor of some of the breadth of the role of PROMs, what PROMs do, and you'll probably see the potential for them for the future. For those of you who are patients and carers in the audience, I mean, I would really like to know, do you think PROMs should be used routinely in clinical care in pulmonary hypertension? How often are you prepared to fill one out? Be honest, we're all busy nowadays. Should it be used as a quality measure of a clinical service? And the big million-dollar question, do we need a clinical trial to find out if PROMs improves patient health in pulmonary hypertension, or is actually improving communication and patient satisfaction and quality of life good enough? Thank you very much for your attention.
Thank you very much, Simon and Gergely, for this very comprehensive presentation about PROMs in PH. And yeah, this slide actually brings already a couple of questions up, especially should PROMs be used in routine PH care from a patient perspective, but also certainly also from a physician's perspective. The guidelines actually recommend at least to look at it. So I'm absolutely aware that we have made progress also in time, but I think it's worthwhile to look to questions that have been probably posed, and I'd like my colleague Rob to send it to me via the private chat, because I don't think in the comments. Oh yeah, here we go. We have a couple of comments already. And let me have a look to it. If you have any questions, please send them. But if I may start, probably I will do this. I mean, patient-reported outcome measures take time to fill in, and they may bother the patient, and they may make also the patient's life more complicated. So what's the balance between asking the patient systematically using a PROM and probably also to adapt care as a consequence of it versus just putting more burden on the patient? Gergely, from your point, you are a patient representative in the ERN. What's your opinion? And obviously then we go to Dr. Gibbs.
Okay, many thanks for this question. And I already have seen that there were some points that such kind of questionnaire should go online, which might give the opportunity of the patients to fill in whenever it's convenient for them. Some years ago, we made a mini survey within PHA Europe to figure out how patients are actually feeling about these questionnaires, and especially the ones who are available online or in a way of application. And there was a question regarding the frequency. And I do not know whether you have any clue about which was the most popular one, but actually it was 1 week, which means that the patients do not feel as a burden filling out such kind of questionnaires on a weekly basis. We were a little bit surprised about this, but actually, I think it makes sense that you are looking back, for instance, at the weekends, how you, what kind of accomplishments you have, and how was your life, and what you have see as, okay, I managed to do, or in what areas I need some improvement. So it was a 1 week. And it was really the answers which were emphasizing that we should go online. So the paperwork is not very popular nowadays. I know that there are always some hesitation about elder people and patients who might not be very familiar with this, but we have other data on this that it is not linked to the age of the patients, but rather health literacy, which we
Okay.
can change with the help of patient associations.
Yeah, thanks very much. So there is room for improvement, but it's applicable. Simon, what do you think?
Put on a mobile phone for most people because it's quick and easy to do. Keep the questionnaires short and talk to the patients. The healthcare professionals are talking to the patients about what they've filled in and what they've said, and do you think we could help you with this and that? So show the patients that there is something useful comes out of it. It isn't just a form filling exercise.
Right. We do have some questions and still some time for some questions. Bendy van Stinkiste asks, is the impact of therapy on the patient's life also measured by these prompts? And is it readable?
Shall I answer, Gergely? Then you can. The answer is yes. Yes, of course it is. Everything that happens to the patient is measured by a PROM because it's an overarching thing. It tells you, how do you feel? Well, if you're reporting your quality of life is better, you don't have to say so. You just answer the questions. And it could be because the medication has made it better. But it could be because you're on holiday, or it could be, there could be all sorts of things. But we're looking all the time at the integrated effect of everything, not something specific. But if you change nothing other than the medication, then that's presumably what it's measuring.
Right.
And let me add that actually
Yeah,
there's a
Gergely,
sorry
please.
for interrupting. There's a scientific paper which underlines what Simon mentioned. So there's a correlation between PROMs and how patients are doing and how the hemodynamic and other functions are working or progressing. The disease is progressing or not. So there's some papers on this. I do not recall whether we put into the guidelines, but there are definitely papers on this.
And some of the pulmonary hypertension PROMs predict survival.
Oh, that's quite interesting. There's another question by Tessa Lush. Super webinar. Thank you. Thank you for that comment. Prompts essential, but maybe via mobile app where they input daily reports of well-being symptoms, HRQL. Check out an app called SymTrack used for MS. Patient filled in before healthcare appointments, so a doctor or nurse could read the data ahead of the consultation to improve discussions and also have a record of good days, not so good days. That actually goes well into your previous comment from both of you that you can use an app. Simon, from your experience and from your knowledge of your colleagues, how are doctors prepared to look to such data produced by an reported by the patient and produced and documented in an app?
I think there's two things. One is that if it's filled in just before the appointment, then the doctor can talk to the patient about what they filled in. So at the appointment, if that's appropriate. If it's presented to, it's all to do with the presentation, isn't it? If it's presented to doctors, it's actually presenting it to the multidisciplinary team meeting that we really need. So the whole team see it with all, it's an interprofessional team, doctors, nurses, social workers, and so on. So if it's presented to the whole team, it's positively useful when the patient's being discussed. So they'll do it. They'll listen.
Yeah,
All right.
what we learned from sorry, only one sentence. So what we
Okay.
learned from many healthcare providers is that there's no possibility for them to record within their patient data such kind of input from quality of life questionnaires, and it's also a problem that within the minimum data sets we are trying to build up once it comes to registries, it might be difficult, but I really hope that in the future we might have some fields which can be adjusted, and such kind of information can be feed in. Thank you.
Yeah, thank you very much for joining us this afternoon or this evening. Thank you very much, Simon Gibbs. Thank you very much, Gergely, Meszaros, for your insightful presentation, for insightful comments. This webinar has been recorded, will be made available on the Alliance for PH website. And please join us for the next webinar to come. Thank you very much and have a great evening.
Thank you.